Hello, everyone. I'm Connie Lee, and I'm the President and CEO of Angioma Alliance. And today we're talking about CCM and COVID-19, obviously an enormous topic for our members with questions and for the nation and the world at large. Joining us today is Dr. Issam Awad, who is, I'm going to make sure that I don't forget anything, the University of Chicago's John Harper Seeley Professor of Surgery. He leads the neurovascular surgery program and co-leads the stroke and neurovascular care team. He's also director of our CCM Center of Excellence and the chair of our scientific advisory board. And we're also joined with his nurse coordinator, Christina Piedad, and by Dr. Kelly Flemming, who is a neurologist and the medical director of our Center of Excellence at the Mayo Clinic in Rochester, Minnesota. So Dr. Awad, you wanted to do a little bit of an introduction before we start with the question and answers.
Sure, happy to do that. Good morning or good afternoon to whoever is joining in other time zones. Actually, Connie, Dr. Flemming, and myself and Christina have been thinking for the last few days about engaging our patient community. The biggest symptom of this pandemic and virus is anxiety, and everybody wonders how it affects me and my disease. And I think there are common questions that we've encountered related to access to care, to prioritization of care during these very unusual times, and also questions about how the disease affects me or how it might affect the course of corona if I were to catch corona, and so forth. So there are many things for which we do not have full answers, but there are other common sense answers that we will try to share with you, both as clinicians, Dr. Flemming, myself, and as nurse, Christina, and also as scientists and as partners in this worldwide community. And I wanted to also add that we hope that this type of webinar, which so many have joined, really tells us something about how to tackle the specific questions related to neurologic diseases and rare diseases in general. The questions that have come to our attention from you are not very different from those that are being asked by many other people with chronic neurologic conditions or with rare neurologic and neurovascular diseases. So we hope that this will be also a platform to the community at large in neurology and neurosurgery and in other aspects of medicine. Connie, maybe before we start, I don't know if you have it available to you, but do you mind reading the statement that the Scientific Advisory Board has agreed to that we are going to post related to this? Because it would be a good background if you have it available to you.
If you give me one moment, I was not prepared for that.
Okay. You're always prepared for everything, Connie. So if you started with that, this would be a good lead into the issue of the registry.
I have it right now.
All right, very good. Go ahead, Connie.
The consensus statement by the Angioma Alliance Scientific Advisory Board regarding COVID-19 and cavernous angiomas. The Angioma Alliance Scientific Advisory Board will be monitoring any specific reports or emerging concerns about COVID-19 and cavernous angiomas. To date, there is no evidence that cavernous angioma patients will be affected differently by this pandemic than other patients of similar age, medical comorbidities, and levels of disability. Until further evidence arises, patients with cavernous angiomas with recent bleeds, surgery, active seizures, or neurological disability may be a group potentially at higher risk with COVID-19, as with older patients and those with medical morbidities. This implies greater adherence to social distancing, disinfection, and hygiene per CDC guidelines. It also includes avoiding contact with individuals, including family and caretakers, exposed to COVID-19, recently traveling back from areas heavily affected by the disease, or exhibiting fever or other flu-like symptoms until those persons prove negative testing or until 14 or more days after their exposure, travel, or last symptoms. Travel avoidance is recommended unless absolutely necessary until travel advisories related to COVID-19 are lifted. Caregivers and those individuals who are sharing a home with high-risk cavernous angioma patients should follow the same precautions. We have no evidence to advise delaying medical care or imaging for cavernous angioma if recommended by your physician, including necessary travel for medical care and timely evaluation if new neurologic symptoms arise. Patients should continue their seizure medicines and other medications for medical conditions and notify their cavernous angioma doctors about any positive test for COVID-19. It's recommended that patients in clinical trials continue to adhere to ongoing trial procedures and notify their trial investigators about possible testing for COVID-19. Dr. Awad, I was going to leave the last paragraph for you, which is about the registry, or do you want me to continue reading?
I think if you read it, that's good, and I will comment further on what we're doing about it.
Okay. We recommend that physicians, particularly those at Angioma Alliance Centers of Excellence and clinical centers, report to the newly established Angioma Alliance COVID-19 registry any case with cavernous angioma who tests positive for COVID-19. Patients and families may also self-report. To report a cavernous angioma patient who has tested positive for COVID-19, you must have the patient, their guardian, or their healthcare power of attorney's permission to do so. We plan to analyze this information and share results with the patient, clinical, and research communities, as well as publishing the results as appropriate. And so everyone knows there is a report contact form on our website, and the address for that form is www.angioma.org/COVID, so COVID. Back to you.
Thank you, Connie. So I'm sorry about the length of this statement, but it will be posted. Is it posted already, Connie?
Yes, at that same web.
Right. So you can read it in detail, you can chew on it and analyze how it might apply to you. But as always, the devil is in the details, and this is why we are having this webinar, so we can dive a little bit into these details. Now, a couple of words about this registry. So what we are interested in is to answer two questions that are central to the cavernoma community, both patients and scientists, doctors. Those questions have to do with, do cavernoma patients respond differently once they are affected by the COVID-19 than other individuals in the community after adjusting for the age and medical comorbidities status. So we have older people with cavernoma, younger people with cavernoma, people with heart disease, people who smoke and don't smoke, but we do not know if just having a cavernoma makes our course with COVID-19 different, and we will try to answer that question. The other question that is important is within the cavernoma world, if I have more lesions, if I have familial disease versus a single lesion, if I had a recent bleed, if I suffer from epilepsy, will that make my course with COVID-19 any different than those who do not have those conditions within the cavernoma community? This question may also be answerable by this registry. So what we are asking at this point is very simple, is limited to individuals who have had one positive test with COVID. and then we will be following up with the patient or designate to obtain a formal consent from you to have a telephone data gathering session that should take maybe up to 10 or 15 minutes, whereby we would ask you questions about your cavernoma disease and also questions about your demographics, age, sex, other medical conditions, and finally questions about what happened to you with the COVID-19. So was it one test and then later it turned out negative? Was it confirmed? Were you in the hospital? Were you, heaven forbid, in the intensive care unit or even intubated? I hope very rarely the people who did not make it, their family members would share the information with us. The likely outcome will be at 1 month. So it will include individuals who are still recovering from the illness, but we want to hasten this so that we are able to collect data almost in real time and analyze it. The study itself will likely be hosted by the IRB at either the Mayo Clinic or University of Chicago. There will be a consent for no greater than minimal risks related to gathering the information from you in an anonymous fashion, and then to analyze and publish and publicize this information to answer the 2 questions I told you about. So we do not want people to report if they're afraid of COVID. We do not want people to report if a family member had COVID and maybe they're afraid they have one. We understand those are concerns and they are real, and there may be people who are not tested who have the disease, but this study will be limited to individuals who have had a positive test. So we understand it will be skewed toward more symptomatic individuals who qualified for the test, but it will nevertheless answer the questions that we are aiming to answer. And if later questions and answers arise as to why we're not including other people in the study, we'll be happy, Dr. Flemming and I, to address and answer those questions. So without further ado, I want to turn it back to Connie, who will kind of tell us how she wants to run the webinar. You are on mute, Connie.
Okay, we received literally dozens of questions before the webinar today. So we're going to start with those, and then if there is any additional time, we'll follow on with the questions and answers that are being entered right now into the Q&A box during the webinar. If we don't get to those extra questions, I will try to make sure that they get answered afterward in one form or another, probably on in Facebook, in our Facebook group. Or if they're really big questions, then we'll make sure that they get out via our email mailing list. So what we're going to do now is sort of go back and forth between Dr. Awad and Dr. Flemming. Christina Piedad will join in when it's appropriate for her. And I'm going to start with some very basic questions about risk. Is cavernous angioma an underlying condition that would put one in a high-risk category and complicate the virus? And Dr. Awad, did you want to take that one first?
Why don't I have Dr. Flemming take the first one to take the next?
All right, Dr. Flemming, can you take the first one?
Sure. So I just want to reiterate that, and you can hear me okay?
Yes.
Yes, great. I just want to reiterate that the Center for Disease Control identifies the age over 60, a history of heart disease, history of lung disease, immunosuppression, and pregnancy is the highest risk categories. And so some of our patients with cavernous angiomas also have those diseases, and those are the diseases at highest risk. As Dr. Awad mentioned, we are not sure what, excuse me, the risk is going to be to cavernous angioma patients, but we would certainly consider people with recent symptoms from a bleed, recent surgery, or those that may have respiratory muscle involvement from spinal cord or brainstem injury as possible people that have a less robust immune system and may be more susceptible to complications.
So what you're saying is that in general, if you don't fall in one of those categories, you should not be considered immunocompromised for the purpose of COVID?
Correct.
Okay. The question was folks who have seizure and are on anti-seizure meds, are they at risk whether or not they still have a lesion? More at risk?
And I'll listen to Dr. Awad as well on this, but if patients have been stable for over a year and they're on their medications and doing well, or they are off their medications and doing well, I'm not worried that they have higher risk of either contracting it or having increased complications.
Dr. What did you want to add?
Yeah, I think it will also depend on the severity of the COVID-19 illness. So I think if individuals are stressed out in a hospital environment, or heaven forbid with acute respiratory distress complications from COVID-19, these could be conditions that cause hypoxemia, meaning low oxygen, and they could lower seizure thresholds. So my recommendation is to make sure that everybody who has a seizure disorder and is on medications tell their physician at the time of diagnosis of COVID that they have these conditions, so they take those in consideration. Maybe make sure your dose is appropriate or increased during the acute illness and other such precautions. Also, I want to say that a recent publication from China experience suggested actually a very small risk of hemorrhage, about 0.5%, not in cavernoma patients, but in overall patients with COVID-19, and the brain hemorrhages occurred in older patients. And as you know, the Chinese population has a high risk of brain bleeding in older patients, and they did have bleeds during these hospitalizations. So it could be that the stress of the illness, particularly in people who are older and hospitalized and on ventilators, could precipitate bleeds. And this is something we will watch closely to see if that applies to cavernous angiomas as it applied to older patients in China. Also, during the stress of the illness, a recent publication in the journal Circulation showed that about 7% of the patients suffer a heart injury during the COVID-19 illness. Again, it is a stress type injury. It is probably more common in people with prior heart disease, but it could also happen as a stress type injury to the heart. And we have to watch that as well. So those are things that are just coming up as we are learning. We will have to play them out and see how they apply specifically to our patients.
And then sort of a follow-on question, when we say recent bleed or recent surgery, do we have some time parameters around that?
Yeah, in general, I think within a year is a good thing. Some people, of course, recover and bounce back from surgery after a month, and this, as if they never had a cavernoma. And those are different from someone who is recuperating from a surgery in the brainstem or thalamus, where they have neurologic setbacks that could last many months. So I think within a year, just kind of look at your own situation, whether your bleed and or surgery are leaving you with some setbacks, then that would apply, in my opinion, as being a slightly higher risk, were you to be also unfortunate to contact COVID-19.
Okay. And then someone asked that they had surgery 3 weeks ago. They've been isolating themselves during that time. They have been using sanitary wipes, washing their hands now that they're going out a little bit. Is there anything else that they should be doing? There's no masks, there's no gloves in their area that they can find. How else should they be protecting themselves and any of our patients?
Right. So I will take this one, and then maybe Dr. Flemming can add things. I think hand washing, social distancing, including including any potential individual in your household who may have had the risks of exposure as we explained them. I think social distancing is extremely important, and hand washing before and after contact with individuals who may have been outside and could have brought the COVID-19 into the house. Avoiding touching the face after you touch packages that you receive, food that is delivered, and also contact with other individuals, and wash your hands first before touching the face. And so if you must go shopping, which all of us have to do to get supplies, some stores have hours to better suit those patients at high risk and the elderly. I would encourage you to take advantage of that, so you are not stuck in big groups where you cannot maintain social distancing. And other services in the communities use local volunteers and shopping online, and some stores can deliver the food to you. You still have to wash your hands after you handle these deliveries, but at least it will eliminate the individual impact of somebody sneezing on you or touching you, who may be incubating the virus and not even know that they are. Dr. Flemming, any other thoughts in this regard?
No, I completely agree that what's really amazing is a lot of local communities are stepping up and trying to help people that are at high risk by having volunteers that shop for you or delivering. And by and far, the biggest, what they think is the biggest risk of contracting the disease is through respiratory, but it does stay on surfaces. So I do wash just with soap and water, the things that we get from the grocery stores or that other people touch, but by and far it's respiratory.
Right, and the virus never lasts more than 3 days on any surface in any situation, except if it's sub-freezing, but short of freezing the virus, it will die if it's not in the host. So things that are 4 days old delivered by Amazon and sitting in the thing are probably in the storage room are probably okay. But wiping stuff before you use it, washing your hands before you touch your face are some of the new normals. Now we just Christina and I had to deal with patients who had surgery just in the past 2 weeks, and both of them were from out of Chicago area. So questions came up about travel and about their own risk during the recovery period. Christina, do you want to comment a little bit on what we've advised these patients as they left the hospital after recent surgery?
I think can you hear me? I'm sorry.
Yes.
Okay. I think it's still always a case-by-case scenario, and there are a lot of traveling limitations now because of COVID, but for the most part, we had the patient last week who had surgery, and he was able to go home just fine without any added risk.
Right. So some of them are heading back to the East Coast, where actually they will have more risk in the community than they had in the hospital. And what we're basically telling them is to be extra careful about social distancing, just like we talked earlier. So that patient will be considered a higher risk, just like an older patient and so forth, and should maintain those added precautions, just because the post-operative period itself is a little period of added stress. People have some trouble sometimes with the lungs as a result of the anesthetic. They may have caught other and also the stress of the surgery puts you at higher risk. So I think for 2, 3, 4 weeks after surgery, even if you feel normal, surgery itself is an added stress, in my opinion. But obviously, if there is neurologic deficit, then it falls into the categories we talked about, where maybe you're breathing could be compromised more than normal, you're going to be fine if the corona doesn't make you very sick. But if the corona makes you very sick and you have that condition, then you may be worse off, and we don't want that.
Okay. Let me move on to the next question. So there are a couple of clinical trials happening right now. One is atorvastatin and the other one is propranolol. Folks are wondering whether or not either one of those medications increases either risk of infection or if it might make the symptoms more severe if you should contract the virus.
So I will let Dr. Flemming address the propranolol and let me address the statin.
Yes, so propranolol is used not only is used for a lot of conditions, including migraine and heart disease. So if you were placed on it for heart reasons, I would talk to your local doctor about the necessity of being on it, because I suspect you need it. If you're put on it just for cavernous malformation and you develop COVID-19 and have respiratory difficulties, given that we don't know that it's beneficial and it could be harmful because it constricts the airway pipes, then I would probably recommend discontinuing it. But I wouldn't discontinue it if you're doing well and not having any problem at the present time.
Okay, Kelly, Dr. Flemming, there's a clinical trial happening in Europe. Is there any special instructions for that group?
I think that they need to contact the local investigator if they have any concerns about being on the medication. But again, I don't think the medication makes you prone to developing COVID, but if you developed COVID and had respiratory symptoms, it's potentially potential to make it worse.
Okay.
But I would
agree with bronchoconstriction effects of propranolol. It's actually contraindicated in very severe asthmatic patients, for example. And if you have acute respiratory distress from the virus, it could be like an asthma condition, and therefore it would become contraindicated. Let me comment about statin. Actually, the short answer is that there is no evidence that statin makes COVID-19 worse in any way. There is some suggestion scientifically that some of the acute response to the virus is mediated by loss of permeability of the respiratory epithelium. And some of this loss of permeability is mediated by Rho kinase, the same thing we talk about as mediating permeability in cavernoma. So there is actually some interest in using very high doses of Rho kinase inhibitors available, for example, in Japan, to treat the ARDS related to COVID-19, the acute respiratory distress, to try to minimize the time on the ventilator and so forth. So if anything, I would think that statin is probably helpful, but we don't know for sure. And I think if you're in a trial, our recommendations currently is to continue to take the drug or placebo that you are given and to report to us any adverse events related to COVID or any COVID infections so that we can consider it in the trial and keep track of it in the trial with safety monitoring and the like.
Next question. Should we try to boost our immune system with things like zinc or anything else with that?
Dr. Flemming, want to start and then I'll add?
Yeah, I think these things that you can get over the counter, like the zinc or the packets of immune boost, we don't know if they really work. They're supplements. And what I really discourage is overusing out of anxiety, trying to control the situation, because there are neurologic conditions that can result from too much excess zinc. So if you decide you are going to do it, I would just do one of those packets or something, but I wouldn't definitely overdo it. But I don't think it's necessarily going to help the situation.
So I want to comment a little bit about the pro-immune state and about zinc. So as you know, patients who have pro-immune conditions like vitamin D deficiency, for example, have higher activity and severity of their cavernoma disease. And people who have genes that predispose them to pro-inflammatory states also have higher activity in CCM disease. So I would not drive pro-immunity if you have cavernoma. I would leave well enough alone to nature, because we may be messing with the devil here and we do not know what we can make better, so we could make things worse. It's similar to the microbiome. You read a paper in Nature and you say, okay, I'm gonna make my microbiome better, but you do not know that when you take certain probiotic that you're not actually making your microbiome worse for cavernomas. And zinc is the same. So there was a paper from Brent Berry's group that I was honored to be a contributor in Nature Communication last year about the role of zinc in cavernoma. The issue there is that that's a mechanistic study, and we have absolutely no idea what that means in terms of taking more zinc or less zinc, or whether zinc is bad or good for you. So we only know that it could affect cavernoma, therefore stay away from playing with it.
Okay. All right. The next question is there a difference in risk between people who have the sporadic form of the illness versus those who have the familial form of the illness? Are there different risk factors, different things they should be aware of?
There are some general and there are some hypothetical questions. So I'm going to talk first about the general issues related to severity of illness, like we pointed out earlier. So people with familial disease may have disabilities related to their lesion burden, for example. So people who have had multiple surgeries, multiple strokes, uncontrolled epilepsy, they are obviously in the higher risk group, similar to older people, because if they were to get COVID with respiratory disease, their ability to fight it may be compromised because of that disability. We talked about that earlier. But I think just merely having familial disease versus sporadic disease, we have no idea if it makes you more vulnerable should you get corona. We're almost sure that it will not make you get corona, more likely or less likely, so that we can probably tell you with some certainty that there is no biologic basis why you should get the disease or not. But if you were to have the disease, there may be some theoretical concerns that the added permeability of our lungs due to the genetic form of the disease, which we know one copy of the gene is in all our cells, including our lungs, we can measure higher permeability in the lungs of patients with CCM familial disease, even when they have no lesions. So whether that will make your acute respiratory distress worse or better after you have COVID-19 is one of the questions we will try to answer by gathering all the cases that have COVID-19 and comparing the familial to the sporadic. But for now, there is certainly nothing you can do about it. So don't worry too much about it until we have more information. Dr. Flemming, any added thoughts on that?
No, I agree. That's why we want to collect the data and try to find out.
Okay. Next question is sort of multifaceted about oxygen exchange and breathing. And it's a combination of questions I'm getting live and what I gave you all ahead of time. So there's concern in both directions. Could potentially the lowered oxygen content that you have as a result of developing some of the respiratory disorders that come with COVID increase the risk of bleeding? And then on the other hand, could it be that sleep apnea that might be coming, central sleep apnea coming from CCM, or is someone else put an unrelated childhood asthmatic condition, could that make one more likely to develop worse symptoms from the COVID?
So I would be more concerned with the low oxygen potentially causing ischemic stroke. In the study that Dr. Awad mentioned from China, there was about 5% of patients had ischemic strokes during the data that they collected, as opposed to necessarily hemorrhage.
Although the animal models are showing that hypoxemia increases vascular growth factor, which is a mediator of bleeding in cavernoma. So this is one of the reasons that we would be wanting anybody with a positive COVID-19 to report, so that we can understand whether there any bleeds occurred during COVID-19 more than they would have been in any regular year. However, I think we need to separate the scientific questions and anxieties from what we call actionable concerns. So there are many things we can worry about, and the only thing we can do about the worry is take Prozac, you know. But there are things that are actionable, that meaning we would do something different about it. So I think this question as to whether my cavernoma will behave worse if I got COVID-19 is already factored in trying to avoid getting COVID-19 by following all the directives, considering yourself a higher risk patient if you have high disease burden or recent bleeding. And then I don't think there is anything you're going to be able to do today to prevent that otherwise, other than waiting and seeing, and we all hope for the best for everyone.
And along with that, then a follow-on question that someone had was about coughing and whether the extreme coughing could lead to more hemorrhage.
No.
Okay.
Yeah.
Okay. Any special advice for people who are healthcare workers and also have a cavernous malformation?
Very good. Dr. Flemming?
Well, I think again, it depends on if one of the high risk factors of recent bleeding or recent surgery come into play, and everyone's human resources area are assessing whether people should continue to work or not based on what other comorbidities or problems they have.
Yeah, so I think if you are volunteering or if you are working as your regular job condition, in that you need to self-identify as having a medical comorbidity, like you would report other medical conditions. Now, if you had a cavernoma that never bled or haven't had a seizure in years, that risk is different from one, like we pointed out before, that may have had a recent bleed and has a hemidiaphragm that doesn't work and having difficulty breathing even without COVID. So I think just looking back at the situation of your case and asking yourself a very common sense question, am I really at higher risk? Should I contact the disease because of my condition and my medical ailment? And if so, then you need to report that to whoever is allowing you to work in this field.
Okay, and here's the last question just about risk. I have a whole bunch of other questions. So there are a number of people who have imaging scheduled in the near future. In some cases, it's the annual maintenance imaging. In other cases, it's trying to make decisions about progression of the illness and surgery. Any suggestions for delaying imaging at this point, or what the circumstances might be where it would make a lot of sense to continue on and have it?
Yes, so I think the biggest difference there is whether you have new symptoms or don't have new symptoms. This is the first question we ask when a patient calls our office and they say, my appointment was in late March, should I keep my appointment? Should I travel to Chicago for my appointment? So if it is a symptom, a new symptom, then we encourage you to get imaging locally if you are not in our area, or we will accommodate your imaging at our center for new symptoms anytime. And then we will review the imaging remotely and then advise whether this type of change that we see on the imaging with the symptoms warrants early intervention, and we'll talk about that a little bit later with some, or whether this is new symptom that we can sit on for now, we can explain it. And so I would say talk to your physician if you have new symptoms. Do not put it off because of COVID. And all the doctors have a system now for remote availability. And that's what you should try to do, is get in touch with your doctor if you have new symptoms. Now, if your study was scheduled electively just to keep an eye on your disease, then this is considered elective. And for now, almost all institutions in this country are delaying these studies and recommending that you not travel for these studies. These may change in the next month. There may be relaxation in certain parts of the country and the world, and heightened in other areas. So you need to listen to the local travel restrictions and talk to your doctor again as to what they advise for routine follow-up. But at our institution, I know the same as at Mayo, we're telling you don't travel for a routine MRI. Is that correct, Dr. Flemming?
Right. And I just really want to reassure people that we are here, we are listening, and we are open for business. It's just we're working differently. We're working through video and phone calls rather than in person. And then we assess whether somebody needs to be seen in person, and trying to get your imaging, as Dr. Awad mentioned, locally versus coming to our institutions. But we are still here for you. So if you have questions, contact your provider. Connie can contact us if you have additional questions beyond this webinar. But I agree, if it's a routine follow-up, we can delay that 8 weeks, 12 weeks, depending on your individual situation.
Yeah, I want to also add that we are, in fact, transitioning many of the visits that do not require face-to-face contact to televisits. So, and this will probably outlast the corona pandemic, and we all will switch to some form of visits whereby the only reason to come and see us in person is to actually get better imaging potentially, or to have a procedure. Otherwise, the cognitive aspect of the visit and the discussion can be done very shortly. We're going to be setting these things up so that part of the clinic will be a person clinic and part of the clinic will be a telehealth type of clinic. And the other aspect, we will not cheat on the quality of the images. So sometimes we might discuss with you doing things differently. And also, if you are in studies, like people who are in the biomarker studies or in the trials, then we ask you to ask the investigator about directives about the follow-up scheduled visit for your study. So there are people who are in follow-up for trial readiness. There are people who are enrolled in atorvastatin trial, and those need to talk to the principal investigator where you were enrolled in the study, and we have special directives to the few individuals who are in these studies to keep the studies going, but also to take care of you and respect your safety. Christina, any added thoughts on this? Since you're the one who takes all the calls, how are you handling the calls these days from people, say, from outside Chicago or from within Chicago that want to come for their visit?
Yeah, I just want to reiterate what Dr. Flemming said. We're definitely still open and available for everyone. And just because all of this kind of disrupted our normal processes, we just have new ones. And anyone that's reporting new symptoms, I obviously talked to you about it, but we have been recommending people to get imaging locally and then send it in for our review, and then we advise from there. But most of it is done over the phone thus far.
Thank you.
Okay, so the next question is about surgeries at this time. In part, you've answered some of this, but let me make sure we get it capsulized. And I know, Dr. Awad, you had a screen you wanted me to share. So a lot of folks have surgery scheduled in the next month. Is this going to be postponing their surgeries? Dr. Awad, what are you doing at this point? And in general, where do you feel the line is between going forward with a surgery versus deferring it now? What factors would you take into consideration? And would you like me to share my screen?
I think there is also the other case probably from New Zealand that we should see first, then you'll share my case. If you're going to show that case, are you?
I wasn't planning to because of confidentiality.
Ah, okay.
Yeah.
So there was, I will use a case that is theoretical without compromising the confidentiality. Then we'll go into the case that I asked Connie to show. So Connie, before you show that, if you don't mind, I wanted to talk about another case first. We'll get to this in a minute.
Okay. Hold on.
So we were asked a question about a patient who is a child who has a huge lesion that is a mass of several centimeters in size that has been growing and causing mass effect on the child brain. The way we would approach this is that this would be a case that we would proceed with surgery now under these conditions because of the benefits of surgery versus the risk of any additional pressure on the brain of the patient. That may not be the case in the jurisdiction where you live. If you are in the middle of New York City and they are overrun by cases, they may just tell you that, sorry, this doesn't make the cut. So that those are things that have to be handled on a case-by-case basis. But let me share with you another case that we are handling. Again, this will not compromise the confidentiality because it has nothing to do about the identity of the patient. But go ahead, show the images. So this is being shared for education and purposes. So this is an individual whom I had seen 2 years ago with a small bleed in the right side of the pons, shown to the left side of the image where there is the 10.6 millimeter bleed. And at that time, the patient was recovering very well and the lesion did not come to the surface of the pons. The trials were not going, so the patient was not enrolled in any trials at that time. This was 2 years ago, and we were following the lesion. Now, in the middle of this COVID crisis, the patient developed new symptoms, and the MRI of the patient is on the right side of the screen, showing that the lesion now has grown from 11 millimeter to about an inch, and there is swelling around the lesion. And obviously, the patient has new symptoms related to the eyes and to the balance and to sensation on the opposite side of the body and coordination, and may have some symptoms related to the face and hearing. So this patient now is in a situation where there is a question as to whether the risk of traveling and being exposed to surgery and making your lungs perhaps compromised by the surgery during the recovery, were you to get COVID-19 from anywhere, like later, would you be worse off because you had the surgery now versus waiting? So the way we advised this patient is that since the bleed had happened several days ago and the patient's symptoms were stable and not worsening, is that it would, at least for the immediate period, be treated conservatively and watch and see, and let's heed the travel restrictions. And we're not bringing this patient from out of state to Chicago for surgery right this minute. However, what we have discussed with the patient is that should you have a worsening of the symptoms, then we are very happy to bring you in and get you into the hospital and gather the team that is involved and do your operation. And we would do the operation like any urgent neurosurgical procedure. And we are open for business and we will do these cases. However, if the bleed stabilizes and the patient's symptoms start to improve, we will repeat an MRI in short order and review that MRI and continue to reassure the patient. So this is a care by long distance that is taking in consideration the COVID crisis and the CCM disease, and very individualized. So if the lesion stabilizes, we keep an eye on it. We don't forget about it. We will repeat the MRI and see if the lesion grows or rebleeds or the symptoms worsen. We will intervene fairly urgently. So I hope that this kind of case with a real picture, with a real situation, helped tell you a little bit how we take it on a case-by-case basis and decide on who we operate on and when.
Excellent. Next question. Are there any medications being used in COVID-19 treatment that we should avoid? And also, are there any that interact with anti-seizure medicines that you know of?
Okay, Dr. Flemming?
I think anytime that you're hospitalized, it would be, if you were hospitalized with the COVID-19, it would be important to let your doctors know the medications you're on. And there are a number of medications that are undergoing clinical trial right now. And so I think the individual providers will have to check with your individual seizure medications and the various antivirals that they're trying for this medication if you were to be hospitalized for that. But I don't know of any interaction with cavernous malformation in particular with the chloroquine or some of the antiviral medications that would increase risk.
Yeah, we looked a little bit at this, and actually Christina did some literature search on this, and the small print on almost any drug will tell you that it alters, it could alter seizure risk, or it could cause some bleeding. Plaquenil, for example, which is hydroxychloroquine, we have a lot of experience with it in cases with lupus and others, and it may be administered to someone with COVID, either as a compassionate treatment or in a trial, because it's not approved for COVID, but doctors may use it. In that case, I think the benefit it may have in COVID exceeds that little small print risk, just like with anything else. So I think, again, it goes back to letting your doctor know about your condition, and they will factor it into the risk and benefits of your individual case.
Okay. And I'm going to ask a question that's not exactly related to us, but there has been a lot of discussion of ibuprofen use with COVID-19. Do you guys want to say anything? You don't have to.
I mean, I don't know the official word, other than there were some early reports from China that maybe that ibuprofen made people worse, but I know that nobody knows for sure if that data is true, but people are recommending Tylenol first here.
Okay. Did you want to say something, Dr. Awad? Or
yeah, I think, you know, for cavernomas itself, you know, the non-steroidal anti-inflammatory medications are kind of a two-edged sword that we don't really understand very well. So there is some evidence that people who may be on them bleed less, but also there is also evidence that somebody can be made to bleed by these drugs. So, so our policy is that if you're on it occasionally for a lesion that didn't bleed, we're not telling you to stop it, but if you're on it after a bleed, maybe we stop it till the lesion stabilizes, and don't use it just overwhelmingly on a regular basis unless it's needed and absolutely necessary medically. So I think, again, I would just tell the doctors that you've got a lesion in the brain that could bleed, and then they'll factor things into the decision.
Okay. If someone is admitted to the hospital, for example, to the ICU, is there any special information that they should be providing to their doctors about cavernous angioma so that they avoid any additional complications, since probably the doctors treating them won't be that familiar with the illness?
Go ahead.
Yeah. Just again reiterating what we've said is that they have a lesion that could bleed, and so that would be important to factor into any medications they may use, as well as if a person has a seizure disorder, to let them know about that, because any lack of sleep, further stress on the body can increase the risk of seizures.
Yeah, so I think just tell them your history, including the CCM, and we addressed before what we know and what we don't know with regard to this.
Okay. And when they do approve a vaccine, would it be safe for CCM patients?
So it sounds like from the CDC that they'll be testing vaccines over the next year, and so we'll learn more over the next year, the safety and efficacy of those type of vaccines for everybody, and we may learn something about CCM as well.
So if patients are wondering whether to enroll in studies for these vaccines, I would encourage it, because the only way we're going to learn if there is a problem in studies. And so if the studies are the best way where the whole world is looking at your case and analyzing your case and understanding it, so it could serve the whole world whether this is safe for our condition or not. But at the end of the day, if it's approved for the general population, we're going to recommend it to be used in cavernomas. There is absolutely no reason why you should not get vaccinated, just like we vaccinate people for the flu. In fact, we recommend that you get your flu vaccine even in the middle of the corona crisis, because the last thing we want is to have both flu and corona on top of each other.
Yeah. Okay, a special topic. Any specific recommendations for women who are pregnant with CCM at this time, and any special recommendations for children, for pediatrics?
So go ahead for the pregnancy, and I'll take the children's question.
Can I interrupt 1 second?
Yeah.
If I go over by 5 or 10 minutes, is that a problem? Because I have about four or five questions left. Or do you have a hard stop at 1 o'clock or at
No,
noon?
I'm good.
I'm good too.
Okay. All right.
Yeah. So pregnancy is listed as one of the higher risk conditions on the CDC website, although if you read the entirety, it says that a lot of things are unknown, but we know that pregnant women are more likely to get the flu, for instance, or be susceptible to other infections. So we would treat pregnancy like any other high-risk patient in terms of getting the COVID.
I think the obstetricians are probably more knowledgeable about the impact of COVID-19 on pregnancy than we are. And I think just tell them about your cavernoma condition, and they will probably bring a neurologist or neurosurgeon into the equation. Should you be, so the way we handle pregnancies in general with cavernoma, as you know, is for the cavernoma specialist to be in touch with the high-risk obstetrician, regardless, even if your lesion is asymptomatic. Because the question comes up, should I have a cesarean section or not? Usually it's not, unless there is a problem, but we can help with that decision rather than leaving it to the obstetrician that doesn't know a cavernoma. So I would say, if you're pregnant and have cavernoma, just encourage your cavernoma specialist to be in touch with your high-risk obstetrician. And should you hit COVID on top of it, then having those two people on the team is better than not.
Pediatrics.
So children, you know, as best as we know, do better than the rest of us with COVID. I think eventually, when there is what we call population immunity, meaning the disease spreads so much that almost everybody has been exposed to it, it's the children that will save us, because they'll be the ones that have the immunity and no serious consequences, and eventually they will be good. I am particularly cautious about ill children, children who have neurologic disabilities or very severe seizure disorders like our CCM3 cohorts and so forth. I think we have to be cautious and consider this as a medical comorbidity, as if you were older, not a child. So I think tell the pediatricians about your condition should there be COVID, and consider the child like an elderly in this situation.
We had a bunch of questions from people who have spinal lesions or who have scoliosis secondary to having CCM. A lot of it you've already addressed in sort of a tangential way, but the questions range from whether any sort of diaphragm involvement might reduce the ability to breathe and increase risk for some of the complications. And the same with scoliosis. And for people who are paralyzed with spinal involvement, is it possible that their body wouldn't detect the virus soon enough and therefore get hit harder? Can you just talk to just the spinal population in general?
Dr. Flemming?
Sure. So I don't. Sorry, the one question was about.
Will like these comorbidities, neurologic conditions like high hemidiaphragm or respiratory difficulty or even paralysis make you less likely to be detected to have the COVID, or make you worse off if you were to get COVID?
Right. So if you have spinal cord paralysis that involves the thoracic or cervical level, and you have impaired respiratory, whether it be the diaphragm or just the respiratory accessory muscles involved, then I would think you would be at higher risk for complications from COVID should you develop it. But I don't think that I think there was another question about
detecting COVID, whether you would be less likely to detect COVID.
Thank you. Yeah, I don't think you'd be any less likely than anyone else to detect it. Fever, cough, respiratory symptoms with shortness of breath, those things you should be able to identify.
Yeah, I think the only thing is don't attribute fever to something else because you get urinary tract infections frequently from your paralysis, or you may get regular pneumonitis problems. Don't blow it off. In this case, if you know, in these days until this COVID passes, consider yourself a potential COVID with these symptoms. I think it's important to report the symptoms rather than to sit on them, so it doesn't become a self-fulfilling prophecy.
Okay, and then last question, I think. This is a double question again. In some of the very rare complications of CCM, and the two in particular that we got questions about are HOD, hypertrophic olivary degeneration, and superficial siderosis. Are there any special precautions or complications that those folks should be aware of?
I don't think so. I think aside from whatever disability they have because of them. So if you have, you know, the olivary degeneration, it is a symptom of a brainstem injury, and it's obviously in reaction to a significant brainstem bleed. And therefore you are more at risk for respiratory problems from that, not from the olivary itself, but from the brainstem dysfunction that could alter breathing. Superficial hemosiderosis, again, if it's causing seizures, it's the seizures that are the issue. If it's causing disability with mobility and things like that, it's those symptoms that will cause it. So I think not primarily those conditions, but we have to be careful about what they mean in terms of your neurologic state.
Dr. Flemming, anything?
No, I agree. It depends on the severity of the disability associated with those conditions.
Yep.
Okay. All right. We had one comment that says, I want to thank the physicians for all they do. This is such a trying time. And then this person wants to specifically say hello to Dr. Flemming from Tennessee. And I want to thank you all for being on the front lines and for taking this so seriously and for helping us to collect the information that we need to know whether or not this illness, COVID-19, has any particular impact on our CCM community. Thank you. Just thank you for being with us on this.
Yeah, I just want to reiterate that we are open. We are here for your questions, and we care about you and your family.
I want to also encourage you that to stay safe, follow all the guidelines that are active in your area. This is going to be a dynamic pandemic. There are going to be ups and downs in what is allowed and what is not allowed. So stay tuned as it plays out. And also, we are all here for you if there are any questions. And please, if you are affected by COVID and have cavernous malformation, do self-report or have family or doctor report your case so that we can be in touch with you and do a telephone evaluation and try to answer the questions for everyone else. There is minimal risk involved with just that.
And We are going to be uploading this webinar to our YouTube channel for those of you who might have missed part of it. I'm getting questions about that. It probably won't be till the weekend because we'll be working on the closed captioning to make sure that everybody can actually understand what's happening in the webinar. But please look for it on the YouTube channel. And again, the registry form is at www.angioma.org/COVID. You'll find it there. Very simple, just name and email and contact information so that we can get back to you. Anything else?
Christina, anything you want to add?
No, I just want to say everyone stay healthy and safe, and we're thinking of you.
Thank you, everybody. Thank you,
Thanks.
Connie, for hosting this and for facilitating this. And I know we're going to be following up soon in terms of setting up how we handle the data from the registry. Thank you.
Thank you.